Welcome to EADV Live. Today's topic, Pediatric Dermatology, Biologics and Disorders of Keratinization and Therapy in Juvenile Localized Scleroderma. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have questions or comments about the subject matter, send them in at any time during the presentation, and our presenters will do their best to address them at the end. If you remember accessing this webcast on the new platform, write your questions in the comment section on the right side of the screen. If you're viewing this from social media, just put your questions in the chat or comment box. Today we are joined by Professor Carmen Salavastru and Professor Angela Hernandez-Martin. Professor Salavastru is first and foremost a dermatologist. Beyond this, she is Professor of Dermatology at the Colentina Clinical Hospital in Bucharest, Romania, where she is also the head of the Pediatric Dermatology Unit. She also happens to be EADV's very own Secretary General, and we're happy to hand over the broadcast to her.
Thank you. Good afternoon, everyone. It is my pleasure to be here today, and I am so happy to welcome a dear colleague and friend, Professor Angela Hernandez-Martin, who is a seasoned dermatologist with a tremendous clinical experience working in the Department of Dermatology, Hospital Infantil Universitario Nino Jesus, Madrid. She is also the secretary of the Spanish Group of Pediatric Dermatology and co-author of more than 180 index publications. Her main area of interest, of course, pediatric dermatology with special attention to keratinization disorders and neurocutaneous diseases. It is my pleasure to give her the floor to talk us about biologics and disorders of keratinization. Dear Angela, thank you so much for accepting our invitation.
Thank you, Carmen, for your nice words, and it's my pleasure, and I feel honored to be here today talking about keratinization disorders therapy. I have no conflicts of interest related to my topic, and along my lecture, I will talk briefly about classical therapy for keratinization disorders. I will give my rationale for biological therapy, and I will share with you a couple of cases from my personal experience. When we look in detail at the classical therapy for congenital ichthyosis, we realize that most of what we do are based on anecdotal reports and or a small series of patients. Actually, there are only 3 randomized controlled trials regarding therapy of congenital ichthyosis, including 2 only with emollients and 1 more essaying calcipatriol ointment as an anti-hyperproliferative agent. But in summary, most therapies and most of what we do is based on expert recommendation or patient preferences. And this is exactly what we gathered in the European Guidelines of Management of Congenital Ichthyosis. There are 2 parts that were published in the British Journal of Dermatology in 2019, but I will focus specifically in systemic therapy. Actually, systemic retinoids are the only option we have, although in Netherson syndrome, we can also use intravenous immunoglobulins. They show inconsistent results. Although we widely use oral retinoids, there are no scientific evidences regarding which is the better option, whether acitretin, isotretinoin, or alitretinoin, which is the best dosage, the optimal starting age, and which are the long-term side effects. I think that we all agree that systemic retinoids are wonderful for epidermolytic ichthyosis, particularly the ones produced by keratin 10 mutations, such is the case of this patient of mine, a girl of 10 years of age, who improved a lot after a few months of therapy with acitretin. Still, we have unsolved issues, including facial erythema, skin fragility, itch, how to prevent scalp cicatricial alopecia, how to improve hypohidrosis, and how to manage inflammation, particularly in erythrodermic patients. This is one of my patients. I will talk about him a little bit more in detail. And he has this severe erythroderma and non-incoercible itching. He was referred to a hospital in February 2017. At that time, she was 17 months old and had a severe ichthyosiform erythroderma. The parents had a parental consanguinity. They were first-degree cousins and showed PK on both sides of the family, although they thought they were just calluses. The boy had suffered several episodes of hypernatremic dehydration and recurrent sepsis and showed an extreme metabolic wasting. The weight and length were very under the normal standard deviation, and the body mass index was also very low. From the dermatologist point of view, he showed an incoercible pruritus, which made it very difficult to see him without suffering. Actually, getting to a clinical diagnosis wasn't difficult because we put together all the clinical manifestations, erythroderma and palmoplantar keratoderma, as well as hypotrichosis, and these all put together fitting some syndrome, some standing for severe dermatitis, allergy, and metabolic wasting. This syndrome was described not so many years ago by Ellis Becker group. Molecular testing confirmed the diagnosis. We found a homozygous desmoglein 1 mutation pathogenic variant. The boy lived far from Madrid, but he came back to be admitted in the ICU 6 months later. He had suffered a new episode of sepsis. He showed a progressive worsening of metabolic wasting. The weight and length were even lower, and the pruritus stand as it used to be at the beginning. And it was unresponsive to any sedative agent, any you may think of, and in high doses. At that point, we didn't really know what to make of this boy. He was on the verge of dying. And we were lucky to find this article in which Amy Paller and co-workers trying to find the correlation between cutaneous barrier dysfunction and inflammation. They took a biopsy of 21 patients, 13 with archiichthyosis or autosomal recessive congenital ichthyosis, 5 more with epidermolytic ichthyosis due to keratin 10 mutations, and 3 more with Netherton syndrome. They found an increased tisular expression of Th17 cytokines and their related genes, which is an immunological profile similar to psoriasis. And they also found data linking the immunological profile with severity. And that made the authors think that we might repurpose the psoriasis biologics targeting the anti-IL-17, IL-23 cytokines for congenital ichthyosis. We couldn't do this tisular research in our patients, but we did flow cytometry, and what was interesting because we found that the interleukin 17 CD4 lymphocytes were much higher in our patient, 10 times higher in our patient than in the controls, the interleukin 17 producing CD4 lymphocytes, I meant. Shortly thereafter, there was this other article in which the same authors went and directly treated 2 patients, 2 children with desmoplakin pathogenic variants. Desmoplakin and desmoglein are 2 desmosomal proteins, and in many cases and in some ways they produce the same cutaneous barrier dysfunction. So there's a clear parallelism in these two effects of the mutation, and actually there are some patients due to either desmoplakin or desmoglein-1 pathogenic variant. In this case, they used ustekinumab at a dose of 0.75 milligrams per kilograms in weeks 0, 4, and then every 12 weeks, which is the same dosage as we use in psoriasis. And they found an improvement of itch from week 2 to 4. So very early, they found that the children were much less itchy. The skin improved not so much, only 50 to 60%, and it took a little bit longer. But they also found a remarkable thriving in these patients, which is also due to the cutaneous barrier impairment. These are pictures of the original article that I was talking about, and which we can see the improvement of the cutaneous lesions. Then we thought of giving ustekinumab to our baby, but at that time, giving ustekinumab in an infant was not so easy. It was, of course, off-label. It has rheumatology nutritionists were using ustekinumab for refractory pediatric Crohn's disease, a dosage much higher, 3 to 6 milligrams per kilograms, and it was approved for psoriasis from 12 years of age at a dose, the same dose as Amy Parler and co-workers were used in their 2 cases. But in our case, that meant that we should give him less than 5 milligrams, which was very, very small dose. So we doubted if that would be enough. We didn't want to mix or to confound between giving something that didn't work or something in which we were not using enough doses. Also, there were warnings about infectious risks, and don't forget that our patient had several episodes of sepsis. Finally, we made the decision because the baby was very, very sick, and we gave him 3 doses of 20 milligrams, which means a dose of 3 milligrams per kilogram at weeks 0, 4, and 12, and then and only 12, but okay. We didn't see any side effects, and we found a quick relief of itch before finishing the first month. However, the skin didn't improve so much. You see that there are almost no differences after 3 months of therapy. Then we thought that there were more agents, and more specifically targeting interleukin-17. At that time, we had secukinumab because ixekizumab was not approved yet, not even in the United States. So we asked for secukinumab, which was again off-label and only marketed for psoriasis in adults at the time, not even for children older than 12 years of age. Unfortunately, there were up to 125 ongoing clinical trials, including one in adults with ichthyosis, which was something that we could fit quite well with our patient cutaneous disease, and there was also a clinical trial in children using a higher dose than that might be of benefit for our children. That was very important for us because we contacted Novartis, which is the laboratory company that markets this biologic, and we asked them for this dosage in a trial, and they were very nice to us and gave it for free. Then we could use in our patient. We then gave our patient 75 milligrams in weeks 0, 1, 2, and 3, and then every month, and we found no side effects. Again, I have to say that the skin hasn't improved much. As you can see, there are almost no differences, but the weight and length was improved a little bit. I mean, like, this was quite reassuring to us because he was very, very small for his age. And we started to see a slow raising of the curves. But the parents stated that the general improvement was very, very evident for them. He was able to sleep. He had nothing to do in itchy. He itches whenever he comes to see me in my office, but the parents are sure that he's much more relaxed and he doesn't scratch himself as much as he used to do. So he is still on secukinumab. As usually happens, this very rare case can't come alone. They come in couples. So a few months later, there was this 10-month-old Caucasian girl who was referred to us, showing a severe exclusiform erythroderma. In this case, there was no parental consanguinity. Again, she had recurrent episodes of sepsis and showed an extreme failure to thrive with weight and length and BMI very low for her age. This is the appearance of this girl when the first time that I saw her, very itchy, very sick, and with this onychodystrophy, very red and very small for her age. Putting together the clinical findings and the pathology, because we took a biopsy, we primarily thought of Netherton syndrome because she was erythrodermic, she had recurrent sepsis and failure to thrive, and also had psoriasiform epidermal hyperplasia, which is something that makes you think of Netherton syndrome. However, we couldn't confirm any mutation in PINK5 gene. We couldn't find any pathogenic variant in inherited immunodeficiency genes and neither in desmosomal genes, because we went directly to test desmoglein-1 and desmoplakin. They were all normal, although we found a heterozygous pathogenic variant in desmoglein-1, which was present both in patient and mother, and the mother was healthy, so this cannot be put as the cause of the child's disease. She came back to a hospital 3 months later, again for recurrent sepsis, and she was so sick that she needed intravenous antibiotic therapy and oxygen therapy. She had been using it for months, and she had been admitted in the place where she lives. Again, we did the flow cytometry, and in this case, the interleukin-17 producing CD4 lymphocytes was much, much higher than in controls, and of course, much, much, much higher than in the first case. In this case, making the decision was much easier. We put her on secukinumab at the same dosages as the previous patient, and she improved a lot in a few weeks. This is at baseline. In 3 weeks, she looked much better, and in 4 months, she was very less itchy, and the cutaneous involvement appeared much healthier. Again, these are the best pictures that I have in which you can tell the difference. This is after 6 months of therapy. In this case, that was very important because we could demonstrate the biological effect of secukinumab in the Th17 cells and the interleukin-17 producing CD4 T cells. So these levels lowered down as we went on putting her on secukinumab. And most importantly, parallel to this improvement in biological effects or consequences, the baby started growing in weight and length almost miraculously, almost reaching the normal levels in percentiles in a few months. So in this second case, there was a clear trend to immunological normalization, a steady improvement of weight and height, and a great improvement of itch. That was very, very remarkable in this case again. And this is how she looks now. She's a very happy girl with her skin almost normal. She had a napkin dermatitis here, diaper dermatitis. She has this hypotrichosis and a little bit of plantar keratoderma, a little bit on the palms also. The study we did in this patient deserved to be published in the New England Journal of Medicine. And if you want to know a little bit more, I invite you to check this article. For those of you who are wondering what happened with the first patient, we also did the monitoring by flow cytometry of the Th17 pathway and interleukin-17 producing cells, and we found no so consistent results. There was kind of a biphasic pattern. We don't really know why in this case we couldn't demonstrate the trend to normalization of immunological parameters. Maybe the boy was older and he had more Th cell memories. There are still unanswered questions, like, for example, for how long will it be efficacious? What are the long-term side effects of biologics in babies, so young babies? Are biologics useful in other keratinization disorders? And what biologic works better? Which is also an interesting question. Well, I think that biologics may work very well in other keratinization disorders. In our flow cytometry studies, we found that the Th17 cells were also raised in children with Netherton syndrome. Regarding which entities and which drugs, there are a variety of them published in the literature so far, and mostly Netherton syndrome. The last one that I've seen is this treatment of Grover disease, which is another keratinization disorder different from ichthyosis. The interesting thing here is that we are using, of course, the Th17 blockers, pathway blockers, but also dupilumab that targets interleukin-4 and 13. And in some cases, dupilumab works better than in others, and we don't really know what to pick right now. I mean, like, we do this because we feel like the patient is more red or more ichthyosic in other times. So it's like we choose blindly the biologic. There are examples of the literature of success. In this case, this boy was treated because he had arthropathy, and they found that the skin improved a lot as well. In this case of a girl with Netherton syndrome, the authors claim that she improved a lot. I think that in these pictures, she looks a little bit worse than at the beginning. In this case, there was a temporary response to dupilumab. As you can see here, she got better and then worse. And in this case, the authors found that some patients with Netherton syndrome may improve with ixekizumab, but others not so much, in particular the redder ones. So in conclusion, patients with congenital ichthyosis and keratinization disorders show immunological anomalies. Immune dysregulation promotes barrier dysfunction, infections, and itch, and biological therapy seems to be a most solid hope, although we still don't know the ideal drug, optimal dose, starting age, and long-term side effects. And I want to finish thanking all the colleagues that work with me, who work with me in this multidisciplinary clinic that I ran from 2016. And of course, I thank the patients and their families for giving me such a support always, and for teaching me many things that I know. And I thank you very much for your attention. And now it's my pleasure. I will, if you have any question, I will be happy to answer at the end of the session. But now it's my pleasure to introduce or to give the word to Professor Salavastru, who was talking about localized juvenile scleroderma.
Thank you so much, Angela. It is always a pleasure to listen to your talks, and you know that we have spoken about this topic, the topic you have presented, and how much hope this gives to our patients with the disorders that you have mentioned. Now moving to the topic that I will speak about today, it's about the juvenile localized scleroderma, the therapeutic approach. I have no conflict of interest related to the topic, and I take also the opportunity to thank you again for contributing to the editorial project Skin and the Heart. Out of the scleroderma cases, 80% are juvenile localized form, and 20% are systemic forms. As with any other condition, the treatment approach is rather tailored according to the clinical variability, disease progression, severity of course, and biomarkers if available. There is unfortunately no uniformly accepted classification for a localized scleroderma due to the breadth of the various clinical forms. So there is a high clinical variability. In 2006, the Padua group proposed a classification for juvenile localized scleroderma that consists of 5 main groups and several subtypes. And also the group of experts that published the European Dermatology Forum S1 guidelines on the diagnosis and treatment of sclerosing disease tailored also a classification that started with the Padua classification. However, the most recent one that is proposed to us in 2020 by the authors of this chapter in Harper's Textbooks of Pediatric Dermatology, it's a simplified one that consists of the types of morphea: plaque, generalized, linear, deep, and mixed. So for today's presentation, I will use the most recent one. In children, morphea has several characteristics, with the linear form being the most prevalent one, up to 65% of the cases, with substantial morbidity due to the involvement of muscle and bones in addition to the skin, with a longer duration of the disease than in adults, almost or more than twice longer, high frequency of relapsing, and risk for major growth disturbance, including limb length differences, joint contracture, and facial atrophy. One additional thing that we encounter in children with localized scleroderma is misdiagnosis and delay in referral. As we can see from this study published by our German colleagues, it is a delay in the diagnosis of consistence of more than 10 months, and usually in the beginning, the general practitioner or the pediatrician cannot offer the right diagnosis in 44% of the cases. And then the local specialists refer the children to the referral center, where a dermatologist in most of the cases is able to set the right diagnosis. However, even in this instance, in 20%, the diagnosis remain unknown, and 8% are misdiagnosed as portwine stains. So I will present a few cases emphasizing on the issues that these children experience. And I will start with this first case, a girl that presented this atrophic plaque on her forehead, and it is quite obvious that it's a morphea, and the Blaschko lines can also be noticed. And what happened actually is that after about 5 years only, when an atrophic plaque appeared on the left side of her scalp, she was referred to a referral center, and since then, since 2015, she is in the care of the center. of our center. The second case, in 2011, preschool girl, the diagnosis was segmental vitiligo, and only in 2016 she attended the referral clinic. So the diagnosis being obviously linear morphea of the head. For the third case, as we all can see here, it's hemiatrophy of the right side of the face. This was a quick referral. The diagnosis was correctly set, and unfortunately, the family rejected the systemic treatment. Another very interesting case, only recently referred. It's interesting because it is a lichen scleroatrophic-like morphea, which is quite rare, and luckily enough responded very well to the systemic treatment. The mixed cases are also rather common, as we can see in this teenage adolescent girl with a linear lesion on the lower left limb, and also with plaques on the abdomen. Another very interesting mixed case, as we can see here, it's the atrophia of the fifth finger of the right hand, and also plaques on the forearms. Several plaques on the abdomen. It is one of the cases that was referred to our clinic, and the referral diagnosis was a very severe one, and the biopsy was also needed in this case. And this is also multiple plaques, as we can see here on the abdomen. And another yet very interesting is the case with gluteal atrophy, as we can see here in a schoolgirl that is also under the care of our referral center, and also some plaques on the abdomen. In most of the cases, the lesions follow the distribution along the lines of Blaschko, which prompted a hypothesis that in this patient with linear morphea, there are susceptible cells that are present in a mosaic state, and that exposure to some trigger factor may result in the development of this condition. We need to assess severity, and for this, in our clinic, we use the quality of life score for children, and also the score of localized scleroderma cutaneous assessment tool with both the components, the localized scleroderma skin activity index and the localized scleroderma skin damage index, and the modified Rotman skin score, which in children needs to be corrected for body mass index for same sex and age, and also for Tanner stage. Unfortunately, there are no reliable objective markers of disease activity available for general clinical use. So the treatment of morphea is rather challenging, and its efficacy is difficult to assess owing to the absence of validated and standardized outcome measures. And the management, of course, is based on the particular subtype, clinical subtype of the disease. Significant concern for disability or growth abnormality, such as linear scleroderma crossing joint lines, facial disease, pansclerotic morphea, systemic, in all these conditions, systemic treatment with methotrexate has become the standard of care. However, patients with morphea experience delay in diagnosis, which likely impacts outcome. Therapeutic decision-making is largely determined by the specialty of the provider rather than disease characteristics, and many treatments with little or no proven efficacy are used, whereas others with proven efficacy are underused. So according to the European Dermatology Forum guideline, as we can see here, we have a special section for children with severe localized scleroderma, and of course methotrexate to which we add usually systemic glucocorticotherapy, is the first line of treatment. Smaller retrospective studies combining methotrexate with oral or intravenous corticosteroids reported a response rate to methotrexate between 71 and 94%. Double-blind randomized placebo-controlled trials compared a 12-month course of oral methotrexate plus prednisone given for 3 months versus prednisone alone for 3 months. Following an initial response in both groups, disease relapse was observed in 71 of the prednisone alone patients versus 32 in the combination group. An open-label extension studies showed that 74% were responders and 50% relapsed by 24 months since the start of methotrexate. Therefore, methotrexate should be continued for at least 24 months to ensure sustained remission. Which is the way methotrexate works as an anti-inflammatory? It is a buildup of intracellular adenosine monophosphate, which subsequently increases extracellular adenosine. Adenosine is thought to be a large contributor to the site-specific anti-inflammatory effects of methotrexate. One factor that contributes to differences in response to methotrexate therapy is genotypic variation related to drug biotransformations and response, which are genetically driven. Single nucleotide polymorphism in the methotrexate metabolism pathway may also help predict response to treatment. There are several practical issues which I'm sure we all are aware of, like the dose, which is once weekly and can be given orally or parenterally. And based on authors' long-term experience, an initial test dose of methotrexate is usually not necessary. And to prevent some of the adverse events, particularly nausea, mouth sores, and perhaps liver enzymes abnormality, methotrexate is usually administered with folic or folinic acid. In children, liver enzyme abnormality occurs up to 30% of patients, but are usually of minimal clinical significance. Laboratory monitoring of liver enzymes, complete blood count, and renal function are recommended approximately 1 month after starting methotrexate or after a dose change, and every 3 to 4 months on a stable dose. Per expert opinion, in order to accurately measure liver enzymes, monitoring labs should be taken 1 or 2 days prior to the weekly scheduled administration of methotrexate. Infections in methotrexate-treated children follow a similar course and response to therapy as untreated children. And for bacterial infection, methotrexate should be held until antibiotics are stopped. Also, per expert opinion, methotrexate can be continued for dental work, but should be held for 1 week before and 2 weeks after major surgery. In 2020, Francesco Zulian and Francesca Tirelli published a new guideline, and also there is a section which addressed to the juvenile localized scleroderma, and we can see that methotrexate together with systemic corticotherapy are considered efficient and still maintain the first line when it comes to recommendation of the treatment. They add also the not so very large experience with mycophenolate mofetil and tocilizumab. Of course, reconstructive interventions are needed and should be discussed with the patient and the family, and there are several surgical options. Generally, the clinical activity or morphea persists for 3 to 4 years, and new lesion may develop even after a longer time interval, but usually no after puberty. So it is a complex condition with a high impact on the patient's quality of life. Thus, early initiation of therapy, it's very important, and multi-specialty collaboration is important in choosing the best treatment approach for the patient. And what does the future hold for us? The British Association of Dermatologists and British Photodermatology Group Guidelines for Topical Photodynamic Therapy list also morphea in their recommendation. There is interesting results of treating generalized recalcitrant morphea with infliximab or generalized deep morphea with everolimus, and very recent publications about the treatment of localized scleroderma with abatacept or tocilizumab. Of course, before I finish this presentation, I think it's important to observe the setting that we are now functioning as healthcare providers. So I will briefly mention COVID-19. I highly recommend you to very nice review articles on systemic immunosuppressive therapy for inflammatory skin diseases in children, an expert consensus-based guidance for clinical decision-making during the COVID-19 pandemic. And as we can see from this table, methotrexate and systemic steroids can be used in an asymptomatic patient. And however, it depends largely on the context when it comes to upper respiratory tract infection with unknown COVID status, or if it is the case of an exposure to this virus or even confirmed COVID-19 infection. So basically, we should consider case by case. Another very important review article on drug safety recommendation in the context of the coronavirus disease 2019 pandemic, released in October 2020, which analyzes the use of various drugs using this color system for classification. We can see that systemic steroids are considered as harmful, and we should avoid them if possible. And the risk of infection is strong dose dependent. However, as we all know, there are some trials showing that there is some benefit of dexamethasone use in oxygen or ventilator dependent patients in COVID disease. So, and what about methotrexate? We can see that methotrexate is listed as low risk of harm, with a low overall risk of infection or infectious complication. However, it may be associated with higher risk when used in combination. What about the vaccination in the patient that are in our care? Of course, this is a period when data are gathering. So the safety and efficacy of severe acute respiratory syndrome coronavirus 2 vaccines in patients with immune-mediated dermatologic diseases requiring immunotherapeutics is unknown. The approved vaccines are expected to be safe for patients on immunotherapeutics with some variability in efficacy, depending on the degree of immunosuppression and type of vaccine given. The review that I highly recommend you to, or I assume that you already are familiar with this analysis, taking into consideration what we already know on the various types of vaccination in the context of use of systemic corticosteroids, for instance, what adverse events are known, and what about the effect of immunity. We can see that it is a variable effect on immunity. And the same for methotrexate. It is considered safe and generally well tolerated with both non-viral and live attenuated or live vaccines. And the variable effect on immunity, most studies involving live virus vaccine showed no significant effect on children's and adult population, and satisfactory vaccine response or adequate seroprotection with a methotrexate dose of 10 to 25 milligrams per week. There is some support for improved response with temporary discontinuation and or second dose. Summary of the safety and efficacy of potential SARS-CoV-2 vaccines for patients on immunotherapeutics. The legend here is in green, there is no minimal risk, and in lighter green, it is a minimal risk, low risk in yellow, and high risk in red. And what about the antibody levels? As we can see, 2 pluses, plus minus, 1 plus. So if we look at the methotrexate, we see that it presents a good profile with a low risk and also a good antibody level, fair antibody level that we can get. And also for systemic corticosteroids, we can see that it is also the case. So the recommendation for vaccination is applied to our patient. The risk to benefit ratio may favor immunization if immunosuppression is low and there is significant risk of disease development. Consider checking antibody titers after vaccination and using additional vaccines if needed to boost the level of protective antibodies. So non-viral or inactivated SARS-CoV-2 vaccine subtypes may be considered before, during, or after immunosuppressive therapy in patients receiving systemic immunosuppressant or immune targeting therapy without significant modification of ongoing treatment. Safety, minimal to no risk of adverse events. Efficacy, variable antibody levels expected depending on vaccine and immunotherapy. So we have in use vaccine platforms with RNA, protein subunit, and non-replicating viral vectors are expected to be safe for patients on immunotherapeutics, and the anticipated efficacy is variable in the setting of systemic immunotherapies. I am sure that all of us are very happy to witness the data gathering, and I am sure that all of us are following the news on CDC website or ECDC and all the other scientific sources that we have in use. I thank you so much for your attention, and I hope that the two topics that have been presented to you today will enrich your experience. Thank you.
All right, so we have time for questions and comments from everybody. Thank you very much for those who have already written in. If you're on the EADV e-learning platform, write them in the comment area, and if you're on social media, put them in the chat box. I think we have a couple questions to get us started already. First of all, a lot of wonderful comments, a very active group today who have said it's very interesting. Very interesting. Some really good positive comments. And we had a question from a member. Do you have any experience with adalimumab for keratinization disorders?
No, I haven't, and I haven't found any experience in the literature either. Maybe because the first article led us to use anti-interleukin 17 pathway, TH17 pathway. I've never used them either.
Okay, and we had another question. Any role of topical therapy in limited plaque morphed in children?
Yes, of course. There are several options that can be used with topical corticosteroids in various potencies, and also calcineurin inhibitors, and also derivatives of vitamin D3. So several options that can also be combined. In our clinic, for instance, we usually practice a rotational strategy with good results. So yes, definitely there is. I have referred today to the severe cases which need systemic treatment.
We have another question here from Catalina Dumitru. What are the top 3 topical and systemic treatments for morphea in children?
So top 3. So, and systemic treatments for morphea in children. So systemic treatments are for the severe forms, as I have already said. So methotrexate in combination with systemic corticotherapy that can be given orally, on intravenously, or intravenously pulses. And for second and third place, I would say that maybe it is methotrexate in monotherapy. And third place, I still hope for the future. Angela, what do you think?
Well, I don't know, because I was going to ask you if you have any experience with abatacept. I've used it once. I've only used it once, and I don't really know the results. I mean, like the morphea, it was an coupe de sabre morphea, and the morphea finally stopped, but not sure that abatacept did anything. I mean, I had to use it because it was progressing despite the use of methotrexate at a nice dose and everything. So it's like no, I just no other things apart of what you said.
Oh, and what about let's say mycophenolate mofetil?
It could be. I've never used it, not even for atopic dermatitis, so I have no experience whatsoever. Have you used it?
Only in adults with the dermatomyositis. Well, so no experience in morphea, of severe forms of morphea. And also we see that are these reports coming about tocilizumab, but still I think we need some time to see how everything will go. So and about the question was also asking about the 3 possibilities of topical. So corticosteroids that are topically applied, and also calcineurin inhibitors are an option, and vitamin D3 derivatives are also an option. However, I would also recommend, but also it depends on the form, some UVA mostly therapy, and also excimer therapy if needed.
All right, now we have another question about the intralesional use of triamcinolone. What about it?
The question is probably regarding morphea. I don't have experience with this treatment. Angela, do you have experience with this?
No, yeah, I'd rather use systemic steroids.
Yes, yeah.
So this is, I mean, the thing that you never do in a child. I mean, like it hurts, and so there's no need for. I mean, you couldn't do it. I mean, you can do this once, the first day, and then no way.
We're getting a lot of comments about the audience is finding morphea very interesting. Let's see, we have another question here. Is there a long-term time frame for the use of systemic retinoids?
No, I guess this is addressed to me. No, although we all use systemic retinoids, and they work very well, and they are the only thing we have no idea about the long-term side effects and how early we should use them in children, which dosage, and on and on. So I think that the patient needs it, because they I mean, when the children are young, the parents can take care of them. But then when they are adolescents, they need to have more time for themselves, and they don't want to be bathed or apply creams on. And in some places, they need the help of their parents. So to some point, you need to use them, and then it's hard. They are hard to stop unless they are females and they want to become pregnant. Otherwise, they tend to need and to want systemic retinoids all lifelong. So it's but we use them because we have nothing else.
Okay, I think we have a complex question now. Which radiological investigation do you prefer to determine the depth of extension in linear morphed in children? Do you have any pearls regarding skin biopsy in such cases?
Well, we if the linear morphea, it's, let's say, how I already showed in let's say a lower limb, ultrasound can be helpful because you can measure the let's say the atrophy of the subcutaneous tissue compared left to right. I know that we don't have in use, but I know that there are several possibilities that have been let's say borrowed from the maxillofacial surgery specific devices to measure the asymmetry when it comes to the face. We don't have that in use. So no specific radiological investigation. However, we do recommend at least once, and usually when we receive the referral, the patient for the first time, we recommend an MRI when the lesions are of the head, on the head and on the face. So at least once we have MRI, because it is important to see that no neurologic involvement is present. So I don't know, Angela, do you have the same?
I do exactly the same, and I have to say that sometimes it's hard because you see the child is perfectly well and healthy, and then you put him or her under general anesthesia, but you need to do it. I mean, you need to make sure. I do exactly the same.
Yes. And pearls regarding skin biopsy, well, it has to be very deep, very deep if needed. Usually it is not need for a skin biopsy in morphea, but if needed, it has to be deep. I mean, you have to have a consistent part of the adipose tissue. And also you have to aim for the border of the lesion where the let's say the purple color is more important. Otherwise, it is a lesion that is not active, and you may end up with not a very clear answer from the pathologist.
Now we had one more question. Oh, we have another question. We had one question. I believe you covered it, but I think it might be good to really emphasize another question about morphea. You talked about the systemic treatments. Cyclosporin in morphea?
I'm afraid I have no experience with this now. Do cyclosporin do you, Angela, have any experience with cyclosporin? No.
I've never used it, and I don't think we should, because the toxicity is bigger, and you can't have a child for 2 years. I mean, you shouldn't have a child for 2 years on cyclosporin, I think.
Yeah, no, me neither. So I don't think it's. I try to remember if I have read something about this, but I can't recall reading about cyclosporin in morphea or.
And so I think we have one more question and time for one more question. Does the type of COVID vaccine differ in relation to methotrexate?
Oh, in our case, it's only one option because the patient, at least in Europe, it's only one approved for children. So yes.
That was easy.
But I think, I don't know. Yeah, I think in the States it is the same. It's the Comirnaty, the Pfizer vaccine that can be. I'm not mistaken. I hope, Angela, isn't it? We have only this option for children so far. I mean, 5 years and above in the States, and 12, yeah, yes, 12 in Europe. So I'm afraid methotrexate is irrelevant in this instance, but
yeah.
Well, okay. I think that is the time we have for today. Do you have any other comments you'd like to give to our audience?
Oh, I just hope that we will have several possibilities in terms of vaccination now to make the connection with the question, because it is a really important question. If the methotrexate can have an influence in how we choose the vaccine. And for adults, indeed, this could be a question. And I am sure that the answer is that we need to discuss if the patient can have preferences. But from what I have presented, it seems that so far, from what we know, we can make different choices. So.
Mm-hmm.
Well,
on my side, I just want to thank the invitation again for taking part in the session. I've been very happy here, and I mean, if anybody have any other question, I will be happy to answer by email or the way they want.
Yes, me too. So I thank you also for this opportunity, and I thank to Professor Hernandez for joining us and for the very interesting lecture, of course.
Thank you both very much. Now, we would like to say a special thank you to Professor Hernandez-Martin and Professor Salavastru for their insightful talk and discussion today. And on behalf of the EADV, thank you for joining us and sharing your thoughts and great questions with us. Now, the EADV is proud to offer numerous opportunities to stay on top of the state-of-the-art in dermatology and venereology. Face-to-face courses are back, and specialists, residents, and now nurses all have the possibility to attend EADV organized courses. We're looking forward to meeting you in some of the most beautiful cities in Europe. To see what's coming up next, go to eadv.org and check under face-to-face education. On the 24th of November, EADV members can join us for the next webcast, Antimicrobial Resistance in Common STIs and How to Manage Genital Candidiasis. At any point, you can check out the Dermatology Podcast, EADV's official podcast, available on all major podcast platforms, including Apple and Spotify. Don't forget to follow or subscribe. Thank you again for joining us, and have a pleasant day.